So, Dr. Lee, it's such a pleasure to be with you today. So, first, I wanted to ask about the partnership between Yale and Jackson Labs. So, can you talk a little bit about that partnership for the saliva COVID-19 test?
Absolutely. So, I want to say it was about 4 or 5 weeks ago when we were introduced to Nate Grabau and Ann Wiley, who are both researchers at Yale. They were looking for a partnership with a CLIA diagnostic lab that was currently actively doing SARS-CoV-2 testing for COVID-19. And the reason for it was because they had developed very elegantly a method to do testing on saliva samples with using very little extraneous supplies, mainly meaning that this was a test that could be potentially done cheaply for the greater community. And so they had been doing this saliva test for some of the basketball players at the NBA. We're just about to get FDA EUA approval, which basically meant that they had a protocol that could be incorporated by clinical diagnostic labs as it was to do SARS-CoV-2 testing on saliva samples. And so when they reached out to us, I learned a little bit more about their situation. Their situation was that while they had a test which was relatively cheap, which used saliva, which is much more preferable than going up and doing a nasal swab, they were doing it totally manually. They were essentially doing the test from beginning to end in a very manual process, which meant that a typical lab with, let's say, 5 or 8 people working in it could only process 100 or 150 tests per day, which is what they were doing. So for the basketball players at the NBA, they were doing it under a research protocol and testing about 100, 150 people per day, which is great. But as you know, we need large-scale, rapid testing for more individuals in a much more efficient manner. So the reason they reached out to us was we had a CLIA lab that was doing COVID-19 testing. We actually currently do about 23% of all the tests run in the state of Connecticut in our diagnostic lab. And that means a lot of automation. And so our collaboration was to see if we could take their test and make it in a manner that was that could be automated, and that would allow for a single lab to not just run 100 or 200 tests a day, but to be able to run thousands of tests per day. And so that's what we're currently working on right now with them.
So, what has Jackson Labs' involvement been with the COVID vaccine development and additional testing since the beginning of this pandemic? It was pretty clear very early on in the pandemic that a vaccine was absolutely needed for a larger audience. So, can you talk a little bit about where Jackson Labs is right now in vaccine development and research?
So, with respect to well, if it's okay, let me just talk a little bit about the testing first. So with regard to the testing, so the Jackson Laboratory has 5 sites around the country. We're based in Ellsworth, Maine, Bar Harbor, Maine, Sacramento, California, and then Farmington, Connecticut. And then we actually have a Shanghai, China operation as well. So in Bar Harbor, Maine, our headquarters are located there, where that's actually where they do a lot of the breeding for mice that we use for medical research. Here in Farmington, Connecticut, we have a research facility as well that is comprised of about 500 plus people, where we also have a clinical diagnostic laboratory, which does genomic tests for diagnosis. And so back in March 23rd, we we actually had a meeting with the governor, Governor Lamont, to tell him that we actually had a diagnostic lab which is prepared to stand up the SARS-CoV-2 test. Even though at that time, you may recall, both the CDC and the federal government was discouraging anyone else from doing the testing. All the samples at that time had to be sent to the CDC for testing. And we realized that just wasn't going to be enough, and we offered our services, and certainly I think that was the right thing to do as we see how things have developed since. We're currently here in our site in Connecticut. We are doing about 23% of all the tests for this that are being conducted in the state on a daily basis. And that, if you also add up some of the tests that we do for some of the hospitals in Maine and some of our employees that are around the country, we're doing about 7,000 tests per day right now. So that's what we're doing here in Connecticut. Our campus in Bar Harbor, Maine, as I mentioned earlier, has been for 90 years really the experts in the world in developing mouse models for medical research. And when the pandemic started, they knew right away as well that they needed to focus in like a laser to prioritize the breeding of a genetically modified mouse, which contains the ACE2 receptor, the human ACE2 receptor, which allows those mice to be infected by the SARS-CoV-2 virus. Normally, SARS-CoV-2 virus would not readily infect common strains of mice. So you have to have this genetically engineered mouse in order to use it in this manner. And so we have that mouse. We've been producing that in as much as we can, providing it to researchers and pharmaceutical companies in the US and around the world to allow them to test their vaccines on these mice to see if they're working. So that's kept them pretty busy as well. So really this two-tiered effort by the Jackson Laboratory, developing mouse models for vaccine development and testing, and doing the testing itself here in Connecticut.
That's pretty amazing. So Jackson Labs is conducting 7,000 tests, or processing, I should say, 7,000 tests for COVID a day. Is that lower than previously? Obviously, testing has increased and it really started to ramp up. Is 7,000, has that gone down on average?
Well, actually, so we've been continuing to ramp up. When we started in March 23rd, we were doing about 100 to 150 tests per day. And so we've been steadily ramping that volume up to now 7,000 tests per day. And the plan is to continue to ramp that up. Our hopes are to get upwards of 12 to 15,000 tests per day. But in addition to just being able to do more volume of testing, it's actually really important to also continue to innovate along with other scientists and entities around the world with the actual testing protocol. So what do I mean by that? Basically, we're continuing to explore ways of making the testing easier for people, making it cheaper, and as well as just essentially being able to increase the volume of the tests that we do. So that's one of the reasons why we were very keen on partnering up with Nathan and his colleagues there at Yale on the Saliva Direct, because certainly being able to collect saliva samples rather than doing the nasal swabs is much easier for individuals, but it also opens up the opportunity to have the collections done easier. You don't have to have, you could theoretically have people just provide saliva in vials and send them to a testing site rather than line up and have a medical professional in all the PPE, do the nasal swabs, etc. The collections would be far easier to do by saliva.
Yeah, absolutely. And another point about COVID testing is not only ramping it up to obviously get more people tested so we can know where the virus is spreading, but also the speed in which people can get their results. So has speed been a priority of Jackson Labs as well?
If anything, I would say that the accuracy of the test and the turnaround, what we refer to is the turnaround time for the test results, have been the two top priorities for the Jackson Laboratory. So I know we've all been seeing stories about laboratories around the country that have been taking 4, 5, 6, 7 days or even longer to get the test results back. And quite frankly, when it gets to being more than 3, 4 days turnaround time, it makes contact tracing very, very difficult. And certainly when you get towards 7, 10 days, the person's recovered by that point. So there's no need to get that test back, and contact tracing is irrelevant, as I mentioned earlier. So for us, we have been consistently getting the results back to our clinical providers within 24 hours. So about 98% of all of our tests since we've started have been turned around in 24 hours. And that's why we, rather than just start to accept more and more samples, which could potentially increase that turnaround time, we're doing it in a manner I think that's responsible so that we keep that 24-hour turnaround time available for all of our providers.
Yeah, absolutely. That's pretty great that you guys have prioritized those two things because those are very critical. So if I could ask, how is the saliva test different than the standard nasal swab? Does it, and I'm not a scientist, so that's why I'm talking to you today. So does it catch a different part of the virus, or is it a little bit more accurate? So just talk to me about the difference between the two.
Well, the saliva direct test, one of the things it does is it just at the beginning, what it does is it has just a heat process where it essentially bursts open the virus, and then you're looking for the what we call the RNA component of the virus and trying to detect that to see if the virus is present. Other methods actually require a little bit more of a sophisticated processing of the virus so that you crack open the virus and allow the RNA to be extracted. That is a little bit more time consuming, a little bit more expensive, but it gives you a higher sensitivity. So what do I mean by that? If I give you numbers, by the typical, using the typical extraction procedure and the nasopharyngeal swabs of a test, of one of these SARS-CoV-2 tests, as long as there is about 500 virus particles per mil in that solution, we'll pick it up. Okay. The saliva, not just the saliva direct, but a lot of these other tests, including the saliva direct, which relies on a different method for the extraction, their limit of detection is about 6,000 viral particles per mil. So you're comparing 500 viral particles per mil to 6,000 viral particles per mil. Now, when a person is very ill, they'll have millions of virus particles, so it won't matter. But as we know from the biology of the virus, sort of in the early days of the infection is sort of when you'll have a lot of this virus that's in your the mucus and in the saliva, etc. So if you actually get tested, then it's probably less of an issue. But then you're still infected with the virus days afterwards. But the amount that's in your saliva and in the nasal swabs continue to go down, and that's when the limited detection is actually important, because you want to be able to still detect some of that virus, but there's less of that virus in the mucus, etc. So, so the sensitivity is important, but then you have to weigh the fact that, well, to get that extra sensitivity, if you have to pay more for that test, or if that test is harder to administer, then what's the trade-off? So, is it better to go with a test that is easier to administer? Maybe it's half the cost of doing the more sensitive test. Things that we refer to as a screening method, which the saliva direct is definitely, sort of straddles that area of testing. Then that's something that we need to seriously consider, because it's a balance of getting a lot of people to get tested frequently and the expense of getting tested. Does that make sense?
Yeah, absolutely. So the question that came up in my head when you were explaining that is it better for an individual, and every situation is different, is it better for an individual to get tested before they're showing symptoms? So if they think possibly, with our habits, if for some reason they weren't wearing a mask, or were in a large group of people, or suspected that someone else was sick, is the best method to get tested before symptoms begin? Then when, obviously, if they get really sick and then get tested, coronavirus will show up in the test. So is that sort of, it's really tough to be able to go get a test when you think you might have been exposed, because you really don't know. But is that the best way to detect it before symptoms show up in those first few days after exposure?
When we talk about screening people, so a large number of people, whether they have symptoms or not, right? In those cases, you want to test the individuals as quickly as possible. So a good example of this is the students that are coming in to start school. They're coming in from all over the country. We know that 20 to 30% of people that have the COVID-19 don't have any symptoms whatsoever. And in fact, I suspect the young students who are resilient to everything, or they feel like they're resilient to everything, won't even recognize if they had some mild symptoms anyways, right? So those individuals, we need to test them all when they come in. There has to be a constant regimen of every so often to get retested, so that if there's an outbreak, we'll pick it up and then be able to try to contain that. Now, on the other side of the equation, there's a lot of testing that goes on. For example, people that need to have surgery done in the hospitals. Well, before they're admitted into the hospitals, the surgeons and all the hospital staff want to know, are they COVID-19 positive or not? If they're not, if they are, they're not going to do the surgery. For those individuals, you would want much more accurate, precise testing, because you're talking about one individual, do they have COVID-19 or not? So a much more sensitive test in those cases, I think, is warranted.
Okay, this is all really, really great to know. So what are you looking ahead to in terms of what a vaccine rollout will look like across the country? So we've seen many stories here in Connecticut and across the country. Vaccines are heading into their different phases, or towards the end of their phases, and Jackson Labs is going to be supplying mice for those trials. So from your perspective, what does a rollout, what is it going to look like? I'm not asking you to predict when it's going to be, but what is it going to look like in terms of higher risk people getting it, or people deciding, I don't have any underlying conditions, maybe I won't get it. So what is it going to look like? What do you think?
So, I really think ultimately that's going to be for the Department of Public Health in the states, various states, to determine. I wouldn't be surprised if the rollout is in a manner that is similar to the flu vaccine. So the vulnerable populations are prioritized to get it first. And we know with COVID-19, for example, the elderly, the immune compromised, if they get COVID, the SARS-CoV-2 virus, they tend to have increased rates of fatality and certainly increased rates of severe infections. So I suspect that would make a lot of sense if the elderly, the immune compromised, and the vulnerable populations had priority, and then others beyond that. I would suspect high on the list also would be, healthcare workers, first responders, etc., because they're in constant contact with vulnerable individuals as well. My hope is that I do hope that something does come out. A vaccine is available, or multiple vaccines are available by the end of this year. What we don't know is how effective those vaccines are going to be. Is it 50% effective, 70% effective, etc.? But also bearing in mind that once they have a vaccine that they think is quote unquote acceptable, let's say it's 60% effective, but it's safe and it'll provide some level of immunity for a period of time, then it's estimated that it would still take 3 to 4 months minimum to just make enough vaccines to distribute. So it's not like the minute a vaccine is has been sort of approved that people will get it. It'll probably be months before many people actually get that vaccine. So a little bit of a waiting game, in store for us.
Yeah, absolutely. Well, that's certainly good to know because this fall and winter will coincide with flu season, and just, being able to protect ourselves against the flu as well, which we know very well with the vaccine and things like that. But obviously with all these safety measures that we have, mask wearing, social distancing, limiting large groups and things like that, it's my hope, and I think you would agree with me that will help keep the rates down until we can really get this vaccine bolstered and have that buildup of a few months. So certainly looking forward to that. And Jackson Labs has been a part of it since the beginning. So we commend you on your work. Thank you so much for, being the voice for science, bioscience in the state and working to address this pandemic. This is month 6 or 7 at this point. So I congratulate you on all the work. And if I could ask one last question.
Please.
So this saliva test is being used for the MBA. Have there been any other inquiries from any other major sports leagues to use this kind of testing? Obviously football's coming up later this week. Is that, is this saliva testing something that other sports leagues want to use?
I have no doubts that other sports leagues are contacting Nate and Anne for this. I can tell you that from our end, since the press release came out on Saliva Direct, we have been inundated by requests from all sectors about whether or not they could get access to that testing. So for example, there are a lot of businesses now, with tens of thousands of employees where they want to have some sort of an easy testing regimen available for their employees. And they're asking, is this something we can partner up and provide for them? And unfortunately, right now, the answer is we're working on trying to make that available, but it's not available in an automated fashion right now. But we keep pushing, and my hope is that we will get that available soon.
Well, best of luck to you and the rest of the Jackson Laboratory team for all of this amazing work. So Dr. Lee, thank you so much. It was a pleasure talking with you, and we hope to have you back soon to talk more about the vaccine when it's finally out.
Wonderful. The pleasure was all mine. Thank you so much.